Okay, thank you very much, Sarko, for the kind introduction, and it's a pleasure and honor to be with you all the way from Holland today. A fantastic opportunity to present the work of our team, and I'm going to be speaking today about groin pain in athletes, the diagnosis, the past, the present, and the future. So I'll just start up my presentation here. So we're going to look back, look at where we are now, and then look where we're headed in the future in terms of the diagnosis of groin pain in athletes. Before we start, I just want to express my thanks and gratitude to the research team at Aspetar over the years since I joined in 2013. Very proud of a lot of the achievements we've made, and with all my colleagues and friends here in Holland as well. And take this opportunity to give a special congratulations to Dr. Popovic and the team on the publication of the Aspetar Sports Medicine Collection. A fantastic achievement. Very proud and happy to have made a small part of this. And I appreciate the huge amount of work that's gone into this. And it's nice to have today as a special occasion to celebrate this. So if we think about the past, the present, and the future, and we start looking back, there are some nice historical articles in the book. And when we look at groin pain, let's start just by considering a simple clinical case. So if we consider a 21-year-old healthy football player with an 8-week gradual onset of groin pain, he feels the pain on sprinting and on changing directions when he's playing, and he feels the pain at the insertion of the right adductors. When we examine the player in clinic, lumbar spine and hips is unremarkable, and you can find his recognizable injury pain when you palpate the insertion of the adductors on the right with resisted adduction testing, and there's also some tightness and pain when you stretch the adductors on the right. Examination of the inguinal canal and the iliopsoas is unremarkable. And just think for yourselves, what would you call this diagnosis in your clinical practice if you saw this football player tomorrow? And again, a second simple clinical case, 31-year-old professional soccer player, gradual onset pain since the last 10 weeks. Pain is felt in the inguinal canal region, and because of the pain, he's unable to sprint or to shoot with full speed. On clinical examination, hip joint and lumbar spine, normal pain-free motion. And on palpation of the inguinal canal, you can find the recognizable injury pain, but there's no palpable inguinal hernia. And when we do resisted abdominal muscle testing, this also provokes his pain in the left inguinal canal. And again here, think for yourself, what name would you give to this diagnosis in your clinical practice? And when we look back, it was clear there was a lot of confusion surrounding this. We did a study where we sent these two clinical cases to 23 experts from around the world, sports medicine physicians like myself, surgeons like Sarko, sports physiotherapists, orthopedic surgeons, and we got a surprising answer. For one simple clinical case, 23 experts, this is the first case, they used 18 different terms. And the second case, the pain felt in the inguinal canal without an inguinal hernia, 23 experts, 22 different terms. Sportman hernia, incipient hernia, inguinal disruption, posterior wall weakness, Gilmore groin, you name it. So a real high number of different terms used to describe a simple clinical presentation. And the question is, does this matter? Well, I think it does for a number of reasons. Firstly, it's really impeding communication between healthcare providers. So often when we discuss cases, if we use different terms, we're talking at cross purposes. And perhaps more importantly, the terms we use to describe a diagnosis influences what patients think they need to get better. So what we name these conditions is really important for athletes to think about their treatments. And this is one of the reasons that groin pain is said to be complex. So yes, we have a complex anatomy, lots of different anatomical structures, organ systems all contained within the groin. But one of the reasons that we think groin pain is complex is because we've come up with so many terms as a medical profession over the years to describe simple clinical presentations, and that's made it Babylonian. So we set out to try and do something about this. We invited the 23 experts, and there were some systems already in place. Per Holmich back in 2007 published a study using a clinical entity approach. And in the book chapter, there's a nice article written by him on groin pain in football players with a systematic diagnostic approach. And Per was at this time the head of the Groin Pain Center. And we convened the World Conference on Groin Pain in Athletes back in 2014 and held a consensus meeting, the Doha Agreement meeting, on terminology and definitions for groin pain in athletes. The 23 experts participated. What's interesting, when you line them up and ask them to pose for the photo, it becomes quite easy to spot who are the football players or who played in the past. And the Doha Agreement meeting was published in 2015 in the British Journal of Sports Medicine. This was a proud moment for me and for the team at Aspetar to put out an international consensus statement on groin pain in athletes. And the consensus statement that includes 4 defined clinical entities: adductor related, iliopsoas related, inguinal and pubic related. We also wanted to stress that the hip is an important cause of groin pain in athletes, and Dr. Rinchu Agricola is talking about this later on today, and that other things can cause pain in the groin, and I come back to this in the present section. So some considerations: this is applying to long-standing groin pain. It's a clinically based system that works around clinical entities. At the current time, there's a lot of confusion and debate about the meaning and potential underlying pathology. And don't forget that multiple clinical entities are possible. And we found in a series of 100 patients who presented to Groin Clinic in Aspetar that 44% had more than one clinical entity. So bear this in mind when you're examining your athletes. We also agreed some terms not to be used. Osteitis pubis, for example, there are some studies done showing that it's not an inflammatory condition. So this is an incorrect nomenclature. And sports hernia as well, there is no hernia. So we felt that these kind of terms were incorrect and agreed as a group not to use these terms anymore. So that's where we're coming from. Confusion. Where are we now? The present situation. So in clinical practice at the moment, we're using the Doha Agreement system for classifying groin pain in athletes. And so the first case, the football player with pain on the adductor insertion, you can find the pain with palpation and reproduce the recognizable injury pain on resisted adduction testing. Then we call this adductor-related groin pain. The second case, pain in the inguinal canal region with recognizable pain on palpation without there being an inguinal hernia. And this is more likely if there's pain on Valsalva or unresisted abdominal muscle testing. This is then inguinal-related groin pain. And it's important when you're examining athletes to understand the anatomy. Now, we British people obviously have some kind of fascination with the anatomy. And we've written together with Andreas Cerner, who's presenting later today, Andrea Mosler and Zarko, We wrote an overview article that's also contained within the chapter, where we bring together anatomy, clinical examination techniques, and the Doha Agreement meeting terminology. This is just an example, and I'm not going to run through it all today. I just want to point you towards this article as a free resource that I think can be meaningful and useful in your clinical practice. So this is to steer you towards that. Just wanted to stress that other things other than these musculotendinous problems can cause pain in the groin. Dr. Agricola is talking about the hip later on, and other causes too. We've seen in groin clinic in Aspetar many cases with nerve entrapment around the groin, or cases where athletes have an actual symptomatic inguinal hernia. So these are important considerations. There can also be even more sinister things going on in the groin. And I just wanted to share one red flag from clinical practice. So when athletes present with pain at night, even after stopping doing sports for some days or weeks, and it's a pain that wakes them up, and it's not just a pain on rolling over in bed or sitting up or lying on it, I'd consider this to be a red flag in clinical practice. And from the past 12 months in the groin clinic here in Holland, a case here at the top of a young athlete who had a lymphoma in his pelvis, and of a male runner who turned out to have Paget's disease in his femur here at the bottom. So it's important that we don't lose sight of the broad differential diagnosis when considering long-standing groin pain in athletes. Now, alongside the work of long-standing groin pain, I'd like to give a special thanks to Andreas Cerner and the rest of the team for the amazing job they've been doing looking at acute onset, so the diagnosis of acute groin injuries in athletes. The link here to Andreas's PhD thesis, which is available free online. And for this, Andreas gathered data on more than 100 athletes who presented with acute groin pain that occurred during sport. What we found is that kicking is the most common injury mechanism in football, and that changing direction is the most common acute groin injury mechanism in other sports. 2/3 of the acute groin injuries are located in the adductor muscle group, of which 90% affect the adductor longus. And 1/3 of the acute groin injuries affect the hip flexors, and there it's about a 50-50 split between the proximal rectus femoris and the iliopsoas muscles. And because adductor longus accounts for the majority of acute groin injuries in athletes, let's focus on that a little more. We looked at the location of injuries, and what we saw is that in acute adductor injuries, 26% of the injuries are located proximally, so where the tendon joins the bone. And that what we saw in those cases is that 3/4 of the time, there was actually a complete rupture of the proximal adductor longus tendon. The other cases were located at the musculotendinous junction, and these were less severe in terms of their injury grade. So beware these proximal adductor injuries, because they are often a complete rupture. We also looked to see if clinical examination can be useful in diagnosing these acute adductor injuries, and it can. So clinical examination can locate injuries in the adductors, and importantly, for those of you who don't have ready or easy access to imaging, then clinical examination, like the lack of pain on palpation, is very valuable in ruling out significant injuries with a very high negative predictive value. So if you palpate everywhere and you can't find any recognizable injury pain, we can have a high level of confidence that there's no injury in the adductors. So this is clinically useful information coming out that's affecting our clinical practice at the present time. And it's also important in terms of the prognosis. So proximal adductor longus injuries are taking a lot longer to recover and return to sports than those at the musculotendinous junction. So these different locations have important implications for the prognosis. So that's where we are at the current time. In long-standing cases, we're using the Doha classification system, and we have new valuable information that's helping inform our clinical practice for diagnosing acute groin injuries. So if we look forwards, what does the future hold? Well, at the moment, we have a number of really nice studies going on. We have one where athletes who come into the groin clinic are examined clinically by Zarko and Andreas, and also undergo additional imaging. Javier is helping us with that, one of the musculoskeletal radiologists at Aspetar. And they all perform these examinations blinded to each other. And this whole process is being adjudicated by Willem Heiboord, our current PhD student, who's doing his PhD thesis on this. And this should give us some more valuable information looking forward about possible tissue diagnoses. And Willem's also been doing some work on the uptake of the Doha Agreement in clinical practice in the world at large, but I'm not going to talk to that because Willem's the next speaker and he'll be presenting new data on that. But that's something that I think will be really important and I'm proud of moving forwards. Another interesting thing would be adolescents with groin pain. So if we go back to the first case, the 28-year-old healthy football player, pain at the right adductor insertion with a gradual onset. And we just changed the fact that he's now 17 years old. So a teenager who's already had his growing spurt. What would be our diagnosis here? Now, this is a case from clinical practice, 17-year-old healthy football player, top level. On the X-ray of his pelvis, we can see here a small fragment around the insertion of the adductor with some sclerosis and an irregular joint surface more marked on the right. He also underwent an MRI examination. These are axial sequences which are fluid sensitive, so fluid is white. And we can see here the short arrow is some edema in the pubic bone. And the long arrow is an oblique fluid line located within the pubic bone. Now, in my experience, these cases are often reported as having osteitis pubis, but that's not the case. A nice article from 2015 here. If we look at the development of the normal healthy pubic apophysis, so these are CT scans, also in the axial plane. And if you look at picture number 1, you can see that the front of the pubic joint is rounded and that the bone surface is irregular, and that this is all still made of cartilage in front of that, which needs to ossify. In picture 2, you can see the bone island, so the ossification center, where that cartilage is starting to ossify. And in picture 3, you can see the normal adult configuration, where the pubic joint is properly squared off, as it looks like later in life. What's interesting is the age at which this bone island is present, and that's normally between the ages of 15 and 21. And in fact, the pubic apophysis, along with the iliac crest, is one of the last apophyses in the human body that fuses. And if we go back and reconsider our 17-year-old football player, he actually has an apophysitis. So we're all familiar with Sever's disease in the heel and Osgood-Schlatter in the knee. This is a pubic apophysitis. The question is this something really rare? And we have great new data coming out from Olivier Matern, who's doing his PhD on this, a physiotherapist working at the Aspire Academy, where they collected data for 4 seasons on more than 500 players, and this is just out in the British Journal of Sports Medicine. And what they saw was that hip and groin injuries are one of the most common groin injuries also in youth soccer, and that the #1 cause of hip and groin injuries in youth soccer, apophyseal osteochondrosis, so apophyseal apophysitis, is the most common cause of time loss injuries in youth soccer. So this is important in our clinical practice, and Olivier has a number of new papers on the way that will hopefully come out this year. So to wrap it all up, groin pain world was confusing and Babylonian, with lots of different terms being used to describe the same simple clinical presentation. At the moment in clinical practice, we're using the Doha Agreement meeting to describe the diagnosis for long-standing groin pain. We have new knowledge about acute groin injuries. Beware the proximal adductor injuries. These can be avulsions which take longer to recover in clinical practice. And looking forward towards the future, new studies coming from Willem Heibor with his PhD, and also work on pubic apophysitis from Olivier. So thanks once again, Shukran, for the invitation. Fantastic to be part of today's event, and thanks to Dr. Popovic and the journal team for their continued support for the Sports Groin Pain Center over the years. It's been a great journey, and I'll just sign out.